Hello, my name is Alyssa Copeland, and I'm with the Department of Children, Youth, and Families. Today, I'm going to talk with you about the Washington State Plan of Safe Care, understanding federal legislative requirements, and Washington's Plan of Safe Care pathways. The federal legislation, the Child Abuse Prevention and Treatment Act, often referred to as CAPTA, requires a plan of safe care be developed for all infants who've experienced prenatal substance exposure. This presentation will provide an overview of the federal legislative requirements and provide updates on Washington State's work to address these changes locally, including developing clear criteria for when infants require a plan of safe care, utilizing Washington's statewide Help Me Grow pathway, and developing clear criteria for the plan of safe care pathway determination, community-based or child welfare. In 2016, when the Comprehensive Addiction and Recovery Act, CARA, was enacted, changes were made to CAPTA legislation specifically related to substance use disorder and prenatal substance exposure. These changes expanded the population requiring a plan of safe care to include families who may not meet criteria for child welfare intervention. It required that the plan of safe care be a family-centered plan as opposed to previously only focusing on the needs of the infant. It clearly defined structure for families to access community-based services and resources, and there were elements of data and reporting that states need to do to the federal government. So the primary tasks for Washington when these changes happened were to define the language in the federal legislation, which means that each state was given the authority to further define the federal legislative language and identify exactly which population or circumstances require a plan of safe care in that state. Washington had to identify criteria for pathway determination, either the plan of safe care community-based pathway or the plan of safe care child welfare pathway. We needed to support a shared understanding of what the plan of safe care body of work is across systems that work with families, and develop and implement a cross-system structure for the plan of safe care body of work to be successful and sustainable. This slide shows our implementation timeline. We received instructions to states in 2017 from the federal government. By early 2019, we were engaged in in-depth technical assistance with the National Center on Substance Abuse and Child Welfare and began our work with stakeholders, partners, providers, and other impacted parties. By 2020, those work groups were beginning the design of the two pathways in Washington. We identified the CAPTA language and defined who required a plan of safe care for Washington, and we began planning for the pilot sites. On June 1st of 2021, the first two pilot sites launched in Yakima and Pierce County, and by December of 2021, we launched our statewide online referral portal, which meant that we were able to offer the community-based plan of safe care pathway at a statewide level as we continued to onboard hospitals. Throughout 2022 and 2023, we engaged birthing hospitals across the state, provided training to onboard to the plan of safe care body of work and utilizing the online referral portal. And we started to work with communities that already were doing wonderful work with this population to bring them into this body of work and provide another layer of support with our statewide Help Me Grow system. We used this time to learn and refine the process from referral process, pathway determination, and we also spent some work aligning our child welfare policy with these federal requirements. 2024 and 2025 is focusing on scaling and achieving statewide implementation. We have a goal of 100% of our birthing hospitals in Washington onboarded to the plan of safe care body of work by the end of calendar year 2024. In June of 2023, a cross-agency letter was sent out to all hospitals signed by leaders of state agencies and the Washington State Hospital Association, requesting that hospital policies be updated to align with the plan of safe care and other related bodies of work supporting the population experiencing perinatal substance use disorder by January 1st of 2025. We've also spent a lot of time focusing on supporting community partnerships and collaborations that are already working with this population to provide long-term recovery supports and resources. Throughout implementation, DCYF has coordinated with state-level agencies within REACH, who administers our Help Me Grow network in Washington, and the Washington State Hospital Association, as well as a multitude of community partners and providers. The Plan of Safe Care is a recommendation of both the Washington Opioid and Overdose Response Plan, dated 2021, and the most recent Washington Maternal Mortality Review Report to the legislature, dated 2023. We've also received national recognition, being held up as an example in the Plan of Safe Care work by both the BUILD Initiative and the Center for Children and Family Futures. The Plan of Safe Care is the largest project in the Washington CAPTA state plan and a primary focus of our citizen review panels, which are a part of our CAPTA work. So hospitals' policies and practices vary widely regarding the testing of newborns for evidence of substance exposure. And when this body of work started implementation, few of our hospitals were using universal screening. Substance use disorders affect gestational parents across all racial, ethnic, and socioeconomic groups and geographic settings. So screening based solely on social or behavioral factors can lead to missed cases and may add to stereotyping and stigma. The Plan of Safe Care initiative collects data on hospital reporting practices to understand when clinicians choose to screen and test for substance exposure and when they are referring families to Child Protective Services. By cross-referencing aggregate racial and demographic data with screening, testing, and CPS referral numbers, DCYF can direct anti-bias training to identified hospitals and communities and support policy that standardizes screening, testing, and referral practices. We're also working with the Washington State Hospital Association to support hospitals to align their policies and procedures across the board when working with this population. We've made improvements to the online referral portal, including strengthening a shared understanding of what safety concerns even means in the context of prenatal substance exposure. And we've integrated a bias checkpoint for users of the online referral portal. Finally, we've aligned our general mandatory reporting training to center anti-bias and the family experience, much of which was informed by this body of work and our support to mandatory reporters who work in birthing hospitals. We also want to support hospitals to feel they have the tools and the resources to provide patient education about the Plan of Safe Care, which includes transparency regarding the fact that a call to DCYF intake might need to be made and what the family should expect. Understanding of the two pathways, that there is a community-based pathway to receive a Plan of Safe Care, and if there is an open child welfare or CPS case, that a Plan of Safe Care will be received as part of that casework. We really want to emphasize how the Plan of Safe Care is a family-centered plan for families experiencing perinatal substance use and newborns who've experienced prenatal substance exposure. We want to support hospitals in any way that's possible to increase coordination and communication with patient providers, for example, a substance use disorder treatment provider, so that they can best understand the family situation at the time that that baby is born and what any current needs for substance use disorder treatment or resources might be. Finally, we want to make sure that during the course of this patient education about the Plan of Safe Care, that hospital staff are receiving a verbal consent from the family for a referral to the community-based Plan of Safe Care pathway administered by Help Me Grow. This verbal consent for referral is critical for making a referral to the community-based pathway, but also having families have the understanding that even if the online referral portal determines a call to DCYF intake is appropriate, DCYF intake will conduct a higher level of assessment to determine if that specific family situation meets the criteria for child welfare intervention. And if it doesn't, they will screen it out. It won't be screened in for a CPS intervention. So we want to have the opportunity to send those screened out intakes back to our Help Me Grow referral portal and refer that family to the community-based pathway so they don't miss out on an opportunity to access voluntary services and supports, especially when their case may not be screening in for child welfare intervention. I'm going to dive a little bit deeper into our two pathways in Washington. First, I'll start with who needs a plan of safe care in Washington. This was the work that was done early on in implementation, defining that federal legislative CAPTA language for Washington state. And what was determined at that time? Newborns who have experienced prenatal substance exposure, newborns who are affected by withdrawal or the range of effects identified by fetal alcohol spectrum disorder or known prenatal alcohol exposure should all have a plan of safe care. Families meeting these criteria will receive a plan of safe care in the community through Help Me Grow or from DCYF if there is an open case. And just to provide a little further definition on those three criteria requiring a plan of safe care, affected by withdrawal is defined as a group of behavioral and physiological features in an infant that follows the abrupt discontinuation of a substance that has the capability of producing physical dependence. No potential clinical signs of withdrawal in the newborn may be attributed to in utero exposure to alcohol or other drugs without appropriate assessment and diagnostic testing to rule out other causes. Fetal alcohol spectrum disorder is the range of effects that can occur in an individual whose birthing parent drank alcohol during the pregnancy. These effects may include physical, mental, behavioral, and/or learning disabilities with possible lifelong impacts. And then finally, prenatal substance exposure, generally speaking, if known exposure occurred to substances with abuse or addictive potential prenatally, then that newborn would also qualify, be eligible for, should have a plan of safe care. All right, this slide provides bit of a high-level overview depicting how the plan of safe care online referral portal works. So once a healthcare provider at the birthing hospital identifies a newborn as being substance exposed, they access the online referral portal. The provider first provides de-identified data on the substance exposed newborn, which automatically gets sent to DCYF. The algorithm then asks the provider questions about safety and other child welfare intervention criteria that helps the provider determine whether a report to child welfare, DCYF intake, is required or a notification to Help Me Grow with a referral for voluntary services. If the newborn requires a report to child welfare, the provider is instructed to call DCYF intake, which is no change in the process pre-plan of safe care. If a report is not required, the healthcare provider completes the plan of safe care referral, and with proper consent in place, it gets sent over to Help Me Grow, along with the family's contact information. Help Me Grow will then reach out to the family to begin the care coordination process. Help Me Grow keeps data on what services and resources families are referred to, and will loop back with the family to determine if the services are received or if additional resources or services might be helpful for them. So within the online referral portal, before answering those questions about pathway determination, users of the portal have to go through what is being referred to as a bias checkpoint. And so they open up a link that opens up a new tab in their browser and are asked to certify that they have reviewed a RAC card. And the RAC card asks hospital workers to reflect on questions such as, do I know enough about the circumstances surrounding prenatal substance exposure to understand the family's risk and protective factors? What is my understanding of the birthing parent's unique cultural background? How are my own experiences impacting my understanding and assessment of the birthing parent? And is the birthing parent's prior history influencing my decision despite evidence of change? These are just brief reflection questions. The document also contains some examples of both protective and risk factors and was a result of enhancements based on listening sessions with families and users of the portal to make the portal a more streamlined and understood process. One major recommendation was to integrate into this portal a checkpoint so that folks who are using the portal have the opportunity to step back and reflect on that individual's family situation, what they know and understand, in order to most appropriately answer those pathway determination questions within the portal. So a little bit more about healthcare providers understanding risk and protective factors. Part of this process is that healthcare providers need to assess whether risk factors related to parental substance use could impact the safety of the infant upon discharge from the hospital, based on what information they are able to know and gather and confirm about the family during their stay in the birthing hospital. This assessment should engage critical thinking, compassion, and a non-judgmental approach. If concerns about the family and risk factors related to the newborn upon discharge are identified, we encourage hospital providers to ask yourself if this is an opportunity to understand parent perspective and provide additional patient education, or is it a risk factor that could impact the safety of the infant upon discharge? Some additional work that came out of our listening sessions in 2023 was developing a shared understanding for safety concerns. So if the pathway determination is to call DCYF intake, the intake screening process will determine if DCYF will screen in or screen out for child welfare involvement. Sharing what you understand as a provider in the hospital about the family's risk and protective factors will help DCYF intake make a screening decision and support safety planning and case planning if screened in the future. Families will be screened in for CPS intervention when the information provided determines a high likelihood the infant could be abused or neglected or experience severe maltreatment as a result of parental substance use without a child welfare intervention at the time of hospital discharge. Like I mentioned earlier, if DCYF intake does not screen in for child welfare intervention, as long as that verbal consent is in place, we can refer the screened out intakes back to Help Me Grow. So let's cover those pathway determination questions in the online referral portal. There's 4 questions total. The first has active use of illicit or non-prescribed substances or misuse of prescribed substances been confirmed through birthing parent report and/or toxicology. This is really important question to understand what type of substance use is occurring for that particular individual. If it happens to be a birthing parent who was able to engage in substance use disorder treatment, and in the context of this question, substance use disorder treatment is referring to either inpatient or outpatient treatment. Many families may report that they're engaged in treatment because they are they're engaged in medication-assisted treatment, MAT, or medications for opioid use disorder, MOUD. These are wonderful interventions that are really supportive of recovery, and especially if somebody is experiencing opioid use disorder. However, if an individual is only engaged in MAT or MOUD and also using illicit substances, non-prescribed substances, or misuse of prescribed substances, and not engaged in substance use disorder treatment, such as inpatient or outpatient, that would not qualify as being engaged in treatment for the purposes of the context of this question. So that A question, is the parent currently engaged in treatment, is referring specifically to inpatient or outpatient treatment. The second B question, has engagement in treatment been 35 to 45 days or less, was a real specific recommendation from our community of lived experts who have experienced perinatal substance use disorder and child welfare intervention themselves, recognizing that engagement in treatment and working towards sobriety and recovery looks different for every person. And so we didn't want to prescribe a specific definitive date, instead wanted to put a range out there and allow the birthing hospital staff and social workers to get an understanding of each family's individual experiences and circumstances in order to determine if that engagement in treatment is nearing stability or not. The second question is the infant experiencing NAS, NOWS, which is neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, or withdrawal symptoms due to prenatal exposure to an illegal, non-prescribed, misused, or undetermined substance. The third question is the infant diagnosed with FASD, or has the infant experienced prenatal alcohol exposure with concerns for the infant's safety also present? And the final question, are there other concerns for the infant's safety upon discharge from the hospital? If the answer to this final question is yes, then a text box will also show up and the birthing hospital user can identify specifically what those other concerns are. And answer yes to any of these 4 pathway questions will determine that the child welfare pathway is appropriate and that the hospital staff should call DCYF intake. And if the answer is no to all 4 of these questions, and the circumstances that you see on this slide apply to the family, a referral to the community pathway is appropriate. So just to quickly review, the circumstances appropriate for the community pathway are a healthcare provider verifies that the birthing parent is taking methadone or buprenorphine or any other opioids as prescribed, and there's no safety concerns. Healthcare provider verification that the birthing parent is taking any medication or combination of medications with abuse potential as prescribed by their clinician, and there's no additional safety concerns. A newborn has experienced prenatal exposure to alcohol or cannabis, and there's no safety concerns. The birthing parent has been engaged in substance use disorder treatment for more than 30 to 45 days and is intentionally building recovery supports and protective factors. So those are all circumstances that would be appropriate for a referral to the community-based pathway. So we'll get into this a little bit more when you learn about how the community-based pathway and Help Me Grow services work, but you'll see that the plan of safe care as a family-centered plan is not going to look much different regardless of the pathway. Families are going to receive referrals to what their highest needs are. That could be housing resources, substance use disorder assessment, treatment, or additional resources, relapse prevention and harm reduction, mental health resources, intimate partner violence resources, home visiting services, parenting supports and childcare, infant supplies, education and resources to support safe sleeping environments for their newborn, education about the period of purple crying, developmental screening, and early intervention services, just to name a few. The plan of safe care could also include elements that are not on this list because it is something that the family has identified as a need for themselves. So we'll wrap it up with a little bit of information about data and reporting. Washington is required to report 3 specific data points related to the plan of safe care to the federal government. We collect data from our DCYF intake and case management data, as well as the de-identified online referral portal data and Help Me Grow service referral data, also de-identified, to report these things to the federal government. So we're reporting the number of newborns requiring a plan of safe care, the number of plans of safe care that have been completed, and so that includes both pathways, and the number of plans of safe care that include a subsequent resource or service referral. In addition, you can see on the bottom right of the screen, the de-identified data that DCYF collects via the online referral portal includes population level information related to zip codes, birthing parents' age, race and ethnicity, substances of exposure, and screening and toxicology information. And again, this is all de-identified at the population level. And then finally, the DCYF Prevention Dashboard is a resource that was launched in summer of 2023, and it provides accessible and current prevention and CPS intake data that is relevant to families experiencing perinatal substance use disorder, among other factors that result in child welfare intervention. But users can have several options to filter data and identify unique characteristics from locations across the state. So you could dial down and see what is happening data-wise, impacting infants and child welfare in your specific community. So this is just a great resource for anybody working within the Plan a Safe Care body of work. Thanks so much for your time.